clear. So we are all practicing modern medicine in some or the other form. And what we all intend to do is to provide the best for our patients. So in this context, I go back to an old study which came in 1986 in the Headache Journal. And the study was about what is the best predictor for resolution of headache. And it turned out to be the patient's perception that they had an opportunity to tell their story and discuss their concern with the treating physician fully at the first visit. So, why I start with this slide is because often people think that as doctors, the reason that we should communicate well is maybe some kind of a bonus to the patient and family. What we need to understand is that we learn communication skills for better clinical outcome. Better clinical outcome does not just come with our ability to diagnose something well or to treat something well. It also includes in how we are able to communicate. That also has an impact. And that is the scientific study here right in front of you. Another reason we should learn communication skills is it keeps the patient safe. It also keeps us safe, because many a times medical errors can lead to catastrophe. It can lead to friction between the patient family and the medical professionals. It can lead to be them suing us, or sometimes even assaulting us, or at least traumatizing us emotionally. So a lot of it can be prevented. Apart from that, the doctor-patient relationship is a complex web. We all know that good history taking is essential for reaching good diagnosis, and good communication skills will enhance our ability to take history, and as a result will improve our diagnostic accuracy. I understand that it is not just history that contributes to good diagnosis, it's also examination and investigation, but the basis always is good history. And better communication skills will enhance our history taking skills, and as a result will improve diagnostic accuracy. Many times you may write a great prescription, the patient takes this to the medical shop person and ask their advice whether he or she should take these medicines. So many a times they have more faith in the medical shop person than on us. Now, this is a matter of trust. This is a matter of effective communication. So good communication skills will help us gain the trust of our patients. It will also help us improve the patient's compliance. For that, we also need to understand that maybe the best prescription may be not practical enough. The patient may have financial issues, logistical issues, social issues, may have beliefs related issues. Therefore, many a times they may not comply with our management advice. And once we are better communicators, we may get patients to comply better, as a result of which we may get better clinical outcome. Good clinical outcome will provide better patient satisfaction. A happy patient and happy family means less stress on us and our team. So happy team, satisfied team, and it will also enhance patient safety. And if the patients are safe, we are also safe. Less chance of litigation and less chance of them harming us. So basically, what I'm trying to better communication skills, you are already communicating well, but When we talk about better communication skills, this is not a bonus for our patients and family. This is purely for our own selfish interest, because good communication skills should should save us time, energy, effort. It should give us better clinical outcome, and it should keep us more safe. So these are the five important things that we should get out of good communication skills. It should save us time, energy, effort, better clinical outcome, and better safety. So keeping this in mind, let us get on to the basics of communication skills. The basics is active listening, and active listening leads to better communication skills. And communication skills is about relationship building. It is this relationship building that will get you success as a professional. It will, this relationship building is going to get you money, name, fame. This relationship building is what is going to keep you safe. No amount of taking signature on consent is going to help if you don't have good relationship with your patients. So to talk about active listening skills, as the name suggests, it is active, it is not passive. It's a very, very dynamic activity, active listening skills. And for today's session, I am dividing this into two parts. One is the body language, the second is the verbal do's and don'ts. And why do we need to learn body language? Because most of the time, when we are communicating with others, we may not be aware of how our body is reacting, of how our body is acting, and how we are conveying messages through body language, which may be contradictory to what we are saying verbally, or it may not match what we are saying verbally. Therefore, having good knowledge of body language will enhance our capability to communicate better. Also, you go to any part of the world, any culture, any language, wherever you go, the major component of human to human conversation is non-verbal. Many times we think it is verbal. No, it is non-verbal. Our eyes speak, our facial expressions speak, our body speaks. And all of this together forms the major chunk of any human to human interaction. In fact, human to animal interaction is also possible only because of body language. So it's a large ocean, lot of things to discover, but obviously today's session does not allow me. No, moreover, a lifetime is not enough to explore every aspect of body language. If you feel interested, Google for body language for doctors, and you will get plenty of stuff. So today I'm just going to talk about around 5, 6, 7, 8 issues. One is eye contact. When patient comes into your OP, stop looking at the computer screen for the from the electronic medical record, or if you are still thankfully still using case sheets, take your head off the case sheet and look up, make eye contact with the patient and family, because that is very important, because you are telling them, I see you, I acknowledge you. Instead of that, if you are not making eye contact, it will reduce satisfaction. Eye contact will improve satisfaction, because eye contact is the starting point of any human relationship. Whether you are meeting the person for the first time or you're meeting that person for the 101st time. Second, don't forget to smile, especially the beginning part of your interaction with that person. As soon as that person comes in, or if you have gone to see that person in the IP room. Now you may think, what's so great about it? I am a nice person, I smile. But we human beings are designed to smile at people we know and like. We usually don't smile at people we don't like. We usually don't smile at people we don't know. Therefore, we are not talking about the natural spontaneous smile that comes to us as a regular emotional display of liking. However, I am talking about professional smile. And this you have to practice because it is a skill. It doesn't come naturally. It's a skill like any other medical skill that you get, like how to, the skill that you have of checking BP. Somebody taught you, you practiced, now you're good at it. Or how to put in a cannula. Somebody taught you, you practiced, and probably now you're good at it. So similarly, smiling, professional smile is a skill. You have to practice it. And for that, you have to plan it. You have to think about it. Let's say you're coming from home and you say, today I will smile at the security person. And then you do smile. Then you consciously smile at the ward boys, ward girls, cleaning ladies, food and beverage uh, people, administrative staff, or physiotherapists, pharmacists, the nurses, your colleagues in other departments, your colleagues in your department. So basically, you have to consciously make an effort to smile. It is a skill, it does not come naturally. So practice it so much that at some point of time, it becomes a spinal reflex. You no longer have to think about it. From a cerebral activity, it becomes a spinal reflex that anything resembling a face passing in front of you will bring a smile to your face. It becomes effortless. It becomes spontaneous. So professional smile, the more you practice, the easier it will come, and it will enhance your ability to make relationships. It will also help you get out of trouble very, very, very easily. And the next thing is good tone of voice, because many a times the problems we get into may not be because of what we said, it may be because of how we said. And therefore our tone, our pitch, all of that matters. Now interestingly, if you practice professional smile, I guarantee you, you will have a good tone of voice. You don't have to practice for good tone of voice, because if you have a happy face, you will have a happy voice. If you have a grumpy face or an angry face, you will have a grumpy sound or an angry sound. Therefore, when you practice professional smile, you get a good, warm, happy tone of voice, free, free, free. Therefore, it's a good package. Practice professional smile and get a good tone of voice, totally free, and stay out of trouble. This will get you out of trouble. This combination of a smile and a happy tone of voice will usually get you out of trouble, or it will prevent trouble from happening at all. So it is preventive medicine. Now let us look at this part, body position. Based on how you position your body in relation to your patient can either increase satisfaction or decrease satisfaction. The key to this is eye contact. If your eye contact is at level or near level to your patient, you improve satisfaction. If your eye contact is above or below, it might look you're looking from above or looking from below. This creates hierarchy. That is superior, inferior kind of a thing. So because you are a medical professional, no matter what position you are in, you're looking from above, you're looking from below. That is, looking from above means standing and looking down at the patient, or looking from below means you're sitting in your chair and looking at somebody standing up. Both of this, because you are a medical professional, the hierarchy is in your favor. You are the senior person, and that person, the other person, is always hierarchically below you. Therefore, when you create eye contact at level, By positioning your body, you create equality and therefore improve satisfaction. Now look at this picture. You have a healthcare professional standing near the head end of the patient and making eye contact. So this is standing, this is on the bed, lying down, semi-reclined, and therefore it is top down. So this will be less satisfactory. Secondly, look at this. For this person to make eye contact with the healthcare professional, the person has to turn the head at an acute angle, and therefore you can see the sternocleidomastoid muscle so prominently. And this can become uncomfortable for the patient after some time. So when you go to the patient's room, in IP, the beginning part of hello, how are you, and all those history taking that you can do at this level. Whether you're standing or sitting, you do at this level, and subsequently, when you want to examine the person, you can move towards the head end of the patient. And look at this picture. Compared to this picture, you have a healthcare professional who is sitting. And here the eye contact is from above to below. Here the eye contact is more at level. More at level. If the person was standing, it will be like this. Instead of that, it is like this. So, and look at this. Where is this person sitting? Near the foot end of the patient. So the person can easily make eye contact, and eye contact is more at level, less hierarchy, more equality. Therefore, this is not only comfortable, this is going to be more satisfactory for the patient and family. If you find this hard to understand, just imagine if you have guests coming into your house and they spend half an hour in your house. You give them tea and snacks, they accept it, they drink your tea, they take your snacks, but all this half an hour they just stand and have this conversation and having tea and snacks. They never sit. Would you be satisfied? Instead of that, instead of spending half an hour, if they come and sit only for 5 minutes and then have this conversation and go, that perhaps would be more satisfactory. So when your guests come and sit down and have a conversation with you, you would find that satisfactory instead of them coming and being in your drawing room for half an hour having a conversation and not sitting at all. Therefore, the same principle applies when you as a doctor visit them in their IP room. Don't spend extra time, whatever time you usually spend. It could be 2 minutes, 3 minutes, 5 minutes, whatever it is, up to you. But whatever time that you spend, of that, spend a small part sitting down and having this conversation. Hello, how are you? And how is the fever, or how is the breathlessness? How is the pain? All of these verbal part of it, if you do sitting, perhaps near the foot end of the patient, that will enhance the satisfaction. So let us say your usual time per patient in your round is, let's say, 5 minutes. And in this 5 minutes, if the initial 2 minutes you can sit down and talk, and rest of the 3 minutes you can get up, examine, and then whatever, give the orders and etc. etc. But that 2 minutes of sitting down and having that conversation will definitely enhance the satisfaction level of your patient and family. The bottom picture, you see a healthcare professional making eye contact at level with the child by bending at the knee. If you can't bend at the knee, you can just pull up a chair, sit, and create the same effect. Most of the time, when we as adults, we interact with children, we bend at the hip and look down upon them. In adults, this creates dissatisfaction. In children, it creates fear. They will be afraid of you. Instead of that, if you position your body in such a way that is, you sit down and make yourself at eye level with them, you will be able to build a better relationship with children. They will not be scared of you, they will not be afraid of you, and gradually you will be able to earn the trust of the children. So in adults, it enhances satisfaction. In children, it reduces the fear of how you position your body. So good eye contact, smile, good tone of voice, and how you position your body, all of these are enhancing satisfaction for your patient and family. A question: how many of you will be satisfied having a conversation with this gentleman who is in this lordos's position? And how many of you would like to have a conversation with this young lady in a slight kyphosis? Remember, this is the usual position we adopt in our university viva exam in front of our examiner, because there we our body language is conveying, I'm here to listen to you, I'm here to listen to every question you have for me. We are unlikely to sit something like this in front of our examiner. So this is conveying eagerness to listen to you. This is conveying, I'm the Lord and Master of this universe. I don't give a damn. I don't care. And this is going to be unsatisfactory. This is going to be satisfactory. Therefore, in our medical practice, always make sure that you adopt kyphosis. If you realize that your back is resting too hard on the backrest of your chair, just reposition yourself. And this is important when you begin the conversation with the patient. If it is just a 2-minute conversation or a 5-minute conversation, doesn't matter. But sometimes for complex, advanced medical conditions, sometimes a counseling session may go longer. In that situation, if you notice the patient or the family member going back into their chair, you can go back in your chair. And subsequently, after some time, if they lean forward, you also lean forward. Then if they lean backwards, you also lean backwards. Basically, you will end up mirroring their movement. And there is a psychology behind it. If you mirror somebody's movement without them knowing it, you make yourself likable to that person. Therefore, but it should be without them knowing it. It should be subtle. So they move forward, you move forward. They move backwards, you move backward. But the starting point always should be a slight kyphosis, a little moving forward. So these are the examples of how we can have a conversation. You don't need to bend your whole spine. Just a part of it is good enough. Just a tilt of the head towards the patient is good enough. But that increases satisfaction. We all have our body space, we have our intimate space, we have our social space, we have our public space. Those with whom we are very intimate, it could be our spouse, our children, very close friends or relatives, we are happy that they stand very close to us or sit very close to us, touching us. But if we are not intimate with somebody, let us say people we meet on a daily basis, we may not sit very close to them. If circumstance, if it is very crowded, for example, in a lift or in a meeting room where there are a lot of people, then we may sit very close. But ideally, we would maintain a little bit of distance. That's called a social distance. And with people we really don't know, they are strangers, we may maintain a little bit more of a distance. That would be the public distance. However, in our profession, we have our patients and family members whom we don't know. They also don't know us. We are not socially, we are not socially interacting. Definitely, we don't have a intimate relationship. And therefore, they are strangers to us and we are strangers to them. However, because of the way medical profession is, we have to intrude into their intimate space, personal space, because we need to examine them, auscultate them, percuss them, palpate them, etc., etc. And therefore, this can be little emotionally distressing. Even though you may say they came to us because they need our services, therefore there is an implied consent. I would agree 100%. There is an implied consent. But the implied consent is the cognitive part of it, the rational part of it. The discomfort comes from the emotional part of it, of somebody whom we don't know touching us. And you can imagine it for yourself. If there is a total stranger who comes and starts touching your tummy or your cheeks, it is going to be uncomfortable. But because as medical professionals, we have to touch our patients, uh, that even though there is an implied consent, the patient also knows. However, it still creates this emotional discomfort, and as a result, that reduces satisfaction. Therefore, before you touch them to examine them, just tell them what you're going to do. For example, you can show your step and just say, let me examine you, let me check you, or I'm going to check you, or I'm going to examine you. So all of these things gives them a head start. Just a momentary head start is all that is required for them to anticipate this, and thereby reducing the emotional discomfort of being touched, uh, even though there is an implied consent. The same thing applies when you go for rounds. You have a bedridden patient because of either debility of age or some neurological debility or multi-organ failure, advanced medical condition, terminally ill, whatever be the reason. And if that patient has soiled himself or herself in their own urine or feces, and then we go for rounds and then we examine them, that is also intruding into their intimate space, because it is going to cause them discomfort, emotional discomfort. If it is your job to clean, remove the diaper or clean their feces and urine, by all means do. However, if it was not your job to do that, then you tell them, I'm sorry, I will come back later, I will go see some other patients, but I'll definitely come back later. Just don't say sorry and leave, because then it will cause anxiety whether you will come back to see them or not. So just tell them, I'm sorry, I will go see some other patients and I'll come back and see you later. So that way you are, by respecting the body space in those circumstances, you are truly respecting the human being. Therefore, respecting body space enhances satisfaction. So these are two examples. Here, there is a healthcare professional who, by the aggressive kyphotic stand, kyphosis, and perhaps the facial expression, is creating so much of discomfort in the patient that the patient is trying to move back as much as possible, as much as the backrest of the chair will allow. And look at the expression. Maybe this healthcare professional means well. I'm sure this healthcare professional means well. However, how the body language is there is creating this kind of a response. And look at this picture. This used to be my senior palliative nurse. She is in Belgium now. And this is one of our patients we went and saw at home care. This was pre-COVID days, therefore no mask and all. And look at this picture. Everything we talked about till now is there. Look at the eye contact, the smile on the face. I'm sure the tone of the voice has to be good. Both bodies in sitting posture. Therefore, eye contact is at level. There's a slight kyphosis of the cervical spine at both sides, a slight tilt of the head towards each other, and a comfortable space between each other. And this is what we should be targeting. This is an excellent picture, and this should be what we should be targeting. Everything that we talked about. And this is possible. We do it in our day-to-day basis. In OP, in IP, home care, everywhere we are doing it. And we are not wasting time doing it. Actually, it saves us time. It enhances relationship. And last but not the least, Never forget the human touch. Here we are not talking about touch while examining the patient or doing some intervention. When people are talking, when they're venting their emotions, a human touch goes a long way. People remember, they will always say, that doctor touched me and consoled me. And it is a big deal for patients and their families if you, as a doctor, do that. In my day-to-day practice, after seeing a patient in the OP, always extend the hand and uh, give a handshake. When seeing patients in IP, before I get out of the uh, room, always give a handshake to the patient and maybe some of the family members also. So these are something that we can do routinely. It enhances their experience of interacting with us. It enhances their satisfaction. It enhances their happiness index. Now, coming to some of the verbal do's and don'ts. Your pain is better now, isn't it? You're feeling better now, isn't it? So these kind of questions, when we ask in a tone like that, these are called leading questions. And many a times the patient may find it difficult to contradict you. No, 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 I am not feeling good at all. They're unlikely to be able to say, especially those patients who are not empowered or coming from an empowered background, financially or socially. So they may just keep quiet or shake their head, and you may get the wrong information. Remember, information is power, but it is useless if it is the wrong information. To get the right information, ask open ended questions. How are you today? And you will get the right answer. So never ask leading questions, always ask open ended questions. Do not minimize my toothache. Just because I have a toothache does not mean my pain is lower than somebody else's cancer pain. And if you say that, oh, why are you jumping around? It is just a toothache. You are minimizing my problem. I will not like you. I'll hate you. Obviously, I'm not going to be satisfied. If you tell me that why are you making a song and dance about your toothache, you go to the pediatric ward of the cancer hospital and there you will see what real suffering is. I don't care, because for me, for anybody, their problem is the biggest problem in the world. Their problem is the only problem in the world. So their problem is the biggest problem in the world. Do not minimize it. Their problem is the only problem in the world. So do not compare their problem to anybody else's. You may be doing it out of a good heart, but it is not going to get you the results that you were hoping for. Actually, it is going to get you negative results. You will have a patient and a family who is dissatisfied with you. On the other hand, if you acknowledge my pain, oh, this must be so difficult for you. I will love you for it. I'll be satisfied with you. And if you normalize my emotional experience of it, you know, I understand why you have been making such a song and dance about it. Anybody in your position would be like this. I get it. I understand. I love you for it. So do not minimize, acknowledge, do not compare, normalize the patient's emotional experience. Don't normalize the patient's experience. Normalize their emotional experience of their distressing symptom. Do not normalize the distressing symptom. Normalize their emotional experience of the distressing symptom. Never give false hope. Never ever give false hope, but always send the patient with hope. So therefore, give realistic hope. For example, in my day-to-day professional life, even today, and on a daily basis, I have to talk to the patient and family. Uh, very often like this, the referring doctor may have referred a patient and no further treatment. No further disease focused treatment, only symptomatic care, supportive care, etc., etc. So I have to tell the patient, see the disease or the family and the family, and to tell them that see the disease is progress beyond what could be done for it, and therefore uh, no further disease focused intervention is possible now. However, I'll make sure that you do not suffer and you continue to be comfortable, and as long as required, you can come back to me. So basically, what I'm conveying that even though your disease is incurable, I will make sure that you remain comfortable. And I'm also conveying that I'm not abandoning you, because you can come back to me as many times as needed. That means as long as he's alive. So two things. One, I'm assuring comfort and peace, and I'm assuring I will not abandon. So these are the things that I am not verbally saying it, but I'm conveying it indirectly by what I'm saying. And when I say the disease is increased and no further possible, but I'll make sure that you remain comfortable and you can come back to me as many times as you need, as and when you need. The usual response I get is, doctor, that is all that we wanted to hear. Even today, before taking this class, I had gone to see a patient who is being discharged, and the lady, the patient is a man, and his wife came out of the room and talking to me. So when I said these words, so her eyes filled up, and she said, "Doctor, that is all that we wanted to hear. That assurance is giving me life, that you will not allow my husband to suffer." So this is something that we can do, that we do on a regular basis. It is not difficult. It may feel difficult in the beginning days if you are new to these areas. However, the more you practice, the better you get at it, and you are going to give more clarity, more dignity, more sense of reinforcement, that sense of empowerment to your patient and family, that everything is not lost. There is still things to be done. So always give hope, but make sure it is realistic hope. Never give false hopes. How is your breathlessness? Much better. So then you write in the case sheet, breathlessness relief. However, if you do not assume and ask another question, so do you have satisfactory relief? Then probably the answer might be, no, not really. I have some relief, but not full relief. So whenever you are talking about symptom management, make sure that you do not assume based on the answer you get. Always ask whether you have satisfactory relief. And if you have achieved satisfactory relief for your patient, great. Or if the patient says not yet, then you know you need to work more to relieve the patient's distress, whether it is physical or emotional or both. So having said all of that, a short history taking incorporating all that we talked about yet. I know that all of you know how to take history because it has been taught to you in first year MBBS, or sorry, when you join the clinical side. However, uh, active listening skills and history taking. So therefore, history taking 2.0. The moment you see the patient and family, whether in the OP or IP, make a greeting. The greeting consists of eye contact. You smile and nod your head and say what is culturally appropriate in your area. And the second thing is get comfortable. If they have come to your OP, offer them seats to sit so that they are comfortable. And if you have gone to their room or their bedside, then you make yourself comfortable, pull up a chair, pull up a stool, anything. So you sit down. Then you start the interview and you start it with an open-ended question. So how can I help? What brings you here? Or tell me. Or if you have gone to see them in the IP, you can ask, so how are you today? Then listen, do not interrupt. Lot of studies, research has gone into it, and unfortunately, it is such a shame that most doctors interrupt on an average before 15 seconds of the patient opening his or her mouth. This is based on studies, average before 15 seconds, 1-5. So not only you should stop your interruption, hold your tongue, listen, you should also encourage them to talk. And how do you do that? You maintain eye contact, you nod your head from time to time, and you can make some appropriate sounds like okay, okay, or maybe ask a few questions. Okay, go on. Then what happened? Okay. Then okay. So these are the few ways you can encourage them so that they know they have your permission to continue to talk. Along the way, if you did not understand something, don't think that you will ask later, because you don't know where this conversation will go. So clarify as you go along. If you did not understand, wait, what was that you said? I did not understand. Also ask about what do they understand? What is their insight? What is how do they see what is going on? So basically, you asked what did the doctors there tell you? What did they tell you after seeing the reports? So these kind of questions will help you understand what does the patient understand, and you will realize that they know a little bit about. They know that some of the information they have is correct. Some of their understanding is totally incorrect, and a lot of their understanding is blank. They have no idea. So usually it is a combination. A major chunk of their understanding is zero, no clue. Some of it is totally off the record. They have totally wrong information. And some of the things that they understand is right. So this is very important for us to understand about what do they understand. Also ask them what their concerns are. What are they most worried about? What is their priority of visiting you? Many times we as medical professionals, our focus is on pathology, and the patient and family's focus is on their distress. And there is a reason they came to you, and we need to understand what that reason is. So therefore, if we ask them, so what are your main priority? What do you really want me to help you with? So they will tell you what the major concerns are. Also, when you have information to share it in a language that is simple, devoid of jargon. And many times this is the hardest part, because we have been taught Greek and Latin from the first day we stepped into medical college. And therefore, Greek and Latin has become our lingua franca. And therefore, when we speak Greek and Latin with each other, we understand it perfectly well. But when we speak Greek and Latin with our patient and families, it sounds like Greek and Latin to them. And surprisingly, they don't understand any of it. For example, if you were to say the USG shows a cyst in the ovary, nothing to worry about. It makes perfect sense to each one of us. However, from the patient or the family's point of view, the conversation in their head may go something like that. I paid money for scan of the tummy, for the stomach scan, and they did the wrong test. They are saying they did USG, though I paid money for stomach scan. So there itself confusion starts. Wrong test. Now they are saying there is cyst in the ovary. Cyst means cancer. I know that. And now they are saying nothing to worry about. There is something fishy going on here. There is something that is not right. So all of this will create suspicion. It will create friction. It will bring loss of trust, loss of clarity, and unnecessarily it will impact our peace of mind. Therefore, we need to learn how to speak common man's language without bringing Greek and Latin. For example, the scan of your stomach has come. It shows there is a slight swelling around your ovary, and the opinion is that is nothing to be worried about. Maybe we can do a similar scan after 6 months to see if there is any difference. So if you speak in a simple language, a common man's language, without USG shows cyst in the ovary, nothing to worry about. So all of this jargon will only create confusion, friction, loss of trust, and it will backfire on us. Most of the time, we don't understand why people don't trust us, why people don't understand what we are conveying. We may be spending half an hour providing information. At the end of the day, they say, doctor said something, I don't know what they said. We don't understand any of this. Whereas alternative medicine practitioners, uh, they have an advantage over us because most of them are good communicators. They're able to communicate in the language that the people understand. You know, in the language of pittam, kafam, jwaram, and these kind of words that they use, it is familiar terrain. And the kind of words we use is unfamiliar terrain for the patient and family. And as a result, they may end up believing and trusting the alternative medicine practitioners and not believe and trust the modern medicine practitioners, even though we are the ones who are trained in science. We are the ones who have a much more rigorous learning period of time, and we are the ones who have better skills and continued research knowledge backing us, our clinical practice, evidence-based practice. But none of this is going to help us if we don't have the trust of our patients and families. It also means discussing the treatment options with the patient and family. We are comfortable having a medical board, we are comfortable having a tumor board, we are comfortable having multiple cross consultations, but we are often not comfortable sitting with the patient and family and discussing treatment options. Remember, the patient's life, their financial issues, their social issues, their logistical issues, they are the specialists in that area. We are not. Therefore, once we have a medical consensus on what constitutes the best option and what constitutes the second best option and what constitutes the third best option, these are the things then we can sit with the patient and family and discuss. Because as a result of participatory decision by consensus, we will be able to arrive at the most practical management option, which may or may not be the most optimum, the best option. It may not, or it may be the best option, but the option that will be done will be the practical option. And for that, we need to sit with the patient and family. The additional advantage of that is then the outcome, we will be equal participants of it. Suppose things did not go well, then we all are in it together. The patient, family, and we, the medical profession, we together took the decision. So it will not be that we imposed a decision on the patient and family, and as a result of which, they go to court, sue us, because this is something that we have sat together. And this relationship building, this sitting together, discussing, and arriving at a consensus on how to proceed further is going to be protective for us medical professionals. So to summarize the interview, then thereafter you can close the interview. And while closing the interview, just before they leave, you can ask, is there anything else that you want to say? Or is there anything else that you want to ask? Dessert, this works as the sweet dish at the end of a good meal. When you have a good meal, at the end of it, when you get something sweet, a dessert, a sweet dish, then you are content. It completes the meal. So when you ask this question, is there anything else you want to ask? It brings a smile to the faces of the patient and family. The discussion may have been very tense, there may have been crying and all of that, but at the end of it, when the last you ask, is there anything else? It brings a smile. That is the sweetness you want to bring at the end. And with that smile, you should leave the IP room, or with that smile, your patient and family should leave your consultation. So that is the importance of asking that question in the end. Also, when you close the interview, you leave the door open. What does that mean? Leaving the door means that if you tell them, okay, next follow up after 2 weeks or after 1 month, you also tell them that in case you need to, you can come early. Now, why I am suggesting that? Because when we go for home care, many a times we see that patients are having some acute problem, and I tell them, why don't you go to your treating doctor? They say that we have been asked to come after 1 month or after 2 weeks or something like that. But I tell them, but this is a problem that has happened since 2 days. Why don't you go? So then they ask, oh, can we do that? So what appears to be common sense for most of us is something that our patient and family are not familiar with. So presently in my practice, my prescription, OP prescription, I add, let's say, review after 1 week, report early if needed. So this is something standard I have put up. So I also tell them, so review after 2 weeks, report early if there is any problem. Don't wait for 2 weeks. So something that you can also incorporate. So that is what means leaving the door open. You are not shutting your door to them, which opens only after 2 weeks or opens only after 1 month. They are free to come and meet you in between early if needed. And in the end, you finish with greeting again by making eye contact, smile, nod your head, and say what is culturally appropriate over there. So the last slide, take home message. All that we have learned today is the expression, the practical expression of empathy. There is no point talking about empathy, sympathy, and their definition, and there is no point in that. The important thing is your behavior, body language, verbal language, everything should provide a positive sense to your patient and family. They should feel that you care. They should feel that this was an empathetic experience. This was satisfactory. They are happy. And you don't have to spend additional time into it. So all of these things will save you time, energy, effort. It will get you better clinical outcome, and it will keep you safer. So it is for our own personal selfish interest that we practice good communication skills. We give them the experience of empathy, and they remember that. They may not remember how many degrees you have. They may not remember how many crores of machinery your hospital has. They may not remember any of it, but they will remember how you made them feel. And if you made them feel, they will go and talk about it. They will do free marketing for you, publicity and marketing. And if the opposite was the effect, then they will do that also. They will go and tell around everybody that doctor is hopeless, this hospital is hopeless, never go there. So most of the time in media, we see all these negative comments. We should do these things for our own selfish interest, but will also create overall a positive energy around us and into the community. With that, I stop here, and